Assalamu alaikum. We are starting today's session with patient female called Mrs. Lisa, 35 years, with complaint of polyuria for 6 months. We will start after this timer. Okay, ready?
Yes, ready.
Yeah, let's go.
Yeah, hello there. I'm Dr. Zain, one of the Dr. Kibling clinic. Am I talking to Miss Lisa, 35-year-old?
Yes.
Miss Lisa, we are here to discuss issue related to your health. After that, I will examine you. Is that all right?
Okay.
So tell me, Miss Lisa, what the problem?
Actually, doctor, I have been suffered from passing urine more than usual since 6 months now. I don't know why, doctor.
Okay, okay. And before this 6 months, have you got it before?
No.
And this polyurium and this increase in your water work, is it also at night? Do you walk at night for this?
Doctor. Yes. I walk 2 to 3 times per day at night.
And is it like increasing in the amount or in the frequency or both?
Both, doctor, both.
Have you noticed any change in the color, like become lighter or darker?
I don't notice.
Yeah, you haven't noticed. Do you have any froth in it, in your water?
No, doctor, I didn't notice.
Any pain during passing water?
Sometimes there is pain. Sometimes.
Where exactly the pain, if you can point with one finger?
During the menstruation, sometimes there is pain. And I think there is also some gravels.
Some graves also.
Yes.
Okay, thank you.
Sometimes.
You have sometimes. And for how long you have these gravels?
It is on and off, doctor. Not always present.
You
but I
have
have
tummy
polyuria all the time.
Okay. Do you have a tummy pain also?
Sometimes I have tummy pains.
Where exactly the pain?
It is big pain over my tummy.
All over your tummy. Does it goes anywhere? Does this pain goes to the groin?
I'm not sure, doctor.
Oh, okay. Do you have any blood in your water work?
No.
Okay. And apart from this increasing in your water work, do you have any change on your weight?
No.
Any change on your appetite?
No.
Okay. And do you feel thirsty more than before?
Yes, doctor. Yes. Yes, doctor. Sometimes I.
Yeah. And when you feel thirsty because of your increase in your water work, or you drink a lot?
Yes, doctor.
And do you think that you are compensating for your increase in your water work?
Actually, doctor, I couldn't compensate. The amount of water work is so high.
Do you feel dizzy when you stand from a sitting position?
Sometimes I feel dizzy.
Do you have any Yeah, you feel dizzy when you stand from a sitting?
Sometimes when I couldn't drink more water and more juices, I feel dizzy.
Do you have any heart racing?
Heart racing? No.
No. Do you have any increase in your body temperature?
No, doctor.
Any lump or bump in your body?
No.
Any shakiness in your hand?
No.
Any panic attack?
No, doctor.
Okay. Any change in your mood?
Yes, sometimes I feel that I have low mood.
And have you sought any medical attention for that?
No, doctor. No, I didn't seek any medical attention for that.
Oh, it's all right. We will gonna address this further in a minute. And then, do you have like any change in your bowel motion?
Usually I have constipation, hard motion, doctor.
Any blood coming from your bad passage?
No.
No. Do you have any heartburn?
Yes, sometimes I have heartburn.
Okay. Do you have any yellow discoloration of your eye?
No.
Okay. Okay. Do you have any joint pain?
No.
Any rash?
Yes, doctor, I have skin rash.
Where exactly? May I see it?
In my leg, doctor. Both in my legs. I will show the rash in the WhatsApp group.
Oh, thank you. Is it painful?
Yes, doctor, is it tender? If I feel it, it become painful.
Is it itchy?
Is it itchy? No.
No. Do you have any cough?
Yes, doctor, I have dry cough.
Dry cough. Do you have any shortness of breath with it?
No.
Okay, okay. And does this cough contain any blood sometimes?
No, it's dry, doctor.
And you say no joint pain, am I right?
Yes.
Okay. Then do you have any headache?
Sometimes I feel headache.
And where exactly in your head?
All over my head. But it
Does
is
this
relieved
head...
by paracetamol, doctor.
Sorry, what you say?
It is relieved by paracetamol.
Okay. And
Simple
does this headache, if we would score it from 1 to 10, how would you score it?
3, 4, something like that.
Does it increase with sneezing or coughing?
No.
Or associated with feeling sick?
No.
Any vision problem?
No, doctor.
Any weakness in your body?
No.
Have you got any trauma to your head?
No.
Okay, okay. Do you have any chest pain?
No.
Regarding your past medical history, do you have any past medical history that I should be aware of?
Actually, doctor, I don't know if it is relevant or not, but I have serious infection in my brain since 1 year. And I have been admitted in the ICU and take antibiotic but now I'm good. No residual thing.
Okay. Have you got any radiation to your head for any reason?
No, doctor.
Okay. And do you have any family history of stone?
No.
Kidney stone? Any family history of gland problem?
No.
Oh, okay. Are you on any kind of medication like water pills?
No.
Any medication for your mood?
No.
Any blood disorder in the family?
No, doctor.
Show me your medication list.
I didn't take any medication, doctor, except paracetamol on and off.
Are you allergic to any medication?
No.
Any over-the-counter like supplement or vitamins?
No.
Have you had any recent travel?
Recent travel, no.
Okay. Any pets at home?
Any what?
Pets at home? Any animals at home?
No.
Okay. What do you do for a living?
I am teacher, doctor. My job is greatly affected by this, doctor. I couldn't go.
We are gonna solve this problem and give you the best treatment, and we may even write a letter to your occupational health worker and give you a sick leave. Is that all right?
Okay, doctor.
Do you smoke?
Yes, doctor.
How much and over how long?
10 cigarettes per day. Now about 5 years.
Actually, smoking is bad for our health. I'm advising you to stop it if you don't mind. Is that all right?
Okay, I'm thinking.
Okay. Do you drink much alcohol?
I drink about 10 units per week.
Okay. So I would like to examine you. During examining you, I may ask you further questions. Is that okay?
Okay, doctor.
Okay. Then I will go to see the rash. It's like a nodule, subcutaneous, by looking. And there, is there any I think no scratching mark around, and it doesn't ooze, no oozing, and When I feel it, is it hot,
Yes.
tender?
Yes, doctor. It's tender.
Okay, okay. And what about the knee and ankle? Does she can move them?
Yes, I can move it.
Okay, okay. Then I see also the rash on her hand, on her left distal forearm. Then I will go for the vital. What about the vital, including blood pressure, sitting and standing?
Normal. It is
Normal.
slightly decreased. يعني 100/70.
There is like postural hypotension, you mean?
No, no. 100/70. Sitting and
Oh,
standing 110/80.
and the rest of the vital are normal. Yes, I understand.
Yes, yes, yes.
Then I will go for her. Then I will go for her eye. Taking a torch, any redness, any pallor, any
Yes,
jaundice,
redness. Yes,
redness,
redness.
redness in the eye.
Yes.
Then I will go for the mouth, any soreness, any thrush, any cyanosis.
No,
The neck for a lymph node and JVB.
no, nothing.
Okay. Then I will auscultate the doing a chest expansion and auscultate the chest, especially the upper lobes. Any fine, any respiratory crackles.
No, nothing.
No crackles at all in the chest.
Yes, no,
Okay, okay. Then I will go for the heart. Any added sound or murmur.
no, nothing.
Okay. Any like palpable and loud B2 and right sternal heave.
No,
Okay. Then I will go for her abdomen by inspection. Any scars, any abnormalities.
no,
Do
no
you have any
organomegaly.
pain? Okay. Do you have any pain at all at your tummy now, Miss Lisa?
No, doctor, no, no,
Okay. So by superficial and deep palpation, any masses, any tenderness?
no, nothing.
Okay. Then I will do for organomegaly, any splenomegaly, hepatomegaly. What about the kidneys?
No organomegaly.
Okay. Then for ascites.
Nothing.
Are you taking any kind of medication for your mood problem, Miss Lisa?
No, doctor.
Then I will check the lower limb, although I have to check it from the start for a lower limb edema.
No edema.
With whom do you live, Miss Lisa?
I live with my husband.
And okay, do you think that you need any kind of a social support?
No, doctor, I'm okay.
Okay,
But
okay.
I am worried about this problem, doctor.
I'm really sorry for that. I would like to ask you a sensitive question. Do you have any casual partner?
No, doctor.
Oh, okay. Any tattooing or piercing?
No.
Okay, then what's your concern?
What's the problem with me, doctor? Why was this?
Okay. I do, after assessing, I appreciate your concern. After assessing you, I think you have got what is called as sarcoidosis. Don't bother yourself. It's a problem in our defense mechanism. Instead of attacking bugs, it starts attacking our own body, including your this skin, your eye, you having the cough, and increasing in your water ward. Maybe due to increase in the salt in your body, we call it calcium. What we need to do now, we will gonna admit you. We will run some blood test and imaging, and we will including a group of specialized team, including the chest physician, joint doctor, mood doctor, and even the nerve doctor. Meanwhile, I need from you to stop smoking. And by the way, do you drive?
Yes, doctor, I can drive.
Do you think this redness in your eye has affected your ability to drive?
No, no,
It's okay. So do you have any other concern?
no, doctor, thank you.
Thank
Okay, suppose the
Okay.
time is up, but I had some disconnection, then that's why the time is changed. So let's start the examiner time. Sorry for this mistake. Go ahead.
Okay, examiner question, what's your diagnosis?
Okay, it seems like she has a hypercalcemia, leading to her to polyuria for differential. It could be like due to sarcoidosis, and also she could have like diabetes, cranial diabetes insipidus, putting in mind that she have a history of long-term history of like encephalitis or meningoencephalitis. But again, is this the history is too long, like between the presentation and the event. Other differential for her polyuria, it could be like a simple UTI. Yeah. Other causes for her polyuria.
Maybe diabetes mellitus?
Maybe psychogenic polydipsia. No, sorry.
Maybe diabetes mellitus?
Against this, she has no change in her appetite and no change in her weight. It could be diabetes, but against this, there is no like polyphagia and no change in her weight. It could be.
Okay.
So we can tell that it could be like hypercalcemia secondary to sarcoidosis. It would be secondary to the diabetes insipidus cranial, but again, is this the long term between the presentation and the condition itself, and it could be like a UTI. It could be psychogenic polydipsia. Yes.
Okay. What is the investigation?
Okay. Apart from the basic lab inflammatory marker, basic lab including full blood count, renal function test with electrolyte, especially the calcium, sodium, potassium, magnesium, phosphorus, and liver function test, and the electrolyte. And also we will gonna do anticholinesterase antibodies. We will check vitamin D for the sarcoidosis also, and we may take yes. Sorry.
Specific investigation for sarcoidosis. What
For the
specific investigation?
sarcoidosis?
Yes.
For the sarcoidosis, I will do anticholinesterase, I think, receptor antibodies. I think we'll check a vitamin D level. We will take a biopsy from the rash, and we will do a chest X-ray and high resolution CT scan for the chest. What else? We may do
what looking for what? X-ray, chest X-ray looking for what?
Yeah, chest X-ray looking for according to the stage of the sarcoidosis. It could be like only hilar lymph node up to the fibrosis. We will do also MRI for the brain because it could be cranial diabetes insipidus secondary to sarcoidosis itself. And what else for the sarcoidosis? Also, we will include the ophthalmologist for the eye because it may be related to the sarcoidosis. What else? Well, we need to do a kidney ultrasound also. Because of the hypercalcemia could lead, I think, to nephrogenic also diabetes insipidus. Yes.
Okay. How to confirm diabetes insipidus?
I have to confirm diabetes insipidus. I think by telling the patient to, I think by supervised. Okay, we will check the osmolarity in the serum and in the urine. The osmolarity in the serum will be high and the sodium will be high. In the urine, it will be the reverse. And we will do like a supervised, like the patient will stop taking water and we will see his urine output and will be supervised. And then we will add the ADH and see the response. This is for the diabetes insipidus. Yes. I think so.
Okay. What is the treatment of the sarcoidosis?
Okay, the treatment of the sarcoidosis, if the patient has extra articular manifestation, I think no, if the patient has like yeah, I think so, extra articular manifestation like the hypercalcemia, one of them, he has a lung issue, he has like a cardiac complication, CNS complication, he needs to start a steroid.
Yes.
I think this is the first line management. I guess so. And then treating the complication and the association of
Okay,
the
what is the stages of sarcoidosis?
on the chest X, you mean on the lung, in the lung?
Stages according to the lung affection, according to the chest X-ray. What is the
Oh,
stage?
okay, it's from stage 0, 1, 2, 3, I think, and 4.
Yes.
Stage 0, you will see nothing, I think. Stage 1, you see hilar lymph node. Stage 3,
Okay.
you will see like, I think with the hilar lymph node, you will see kind of fibrosis. Stage 4 might be like a honeycombing, I'm not sure, really.
Okay. How you can treat cranial diabetes insipidus?
Cranial diabetes insipidus will give a patient the ADH vasopressin.
Yes, okay. How you can treat nephrogenic diabetes insipidus?
By giving the patient thiazide. And of course, we will educate the patient and counsel him about his heart disease, like drinking a lot of water, and management of any complication.
Okay. Which diseases cause diabetes insipidus and diabetes mellitus؟ هو التايم اب صح؟
Both.
اوكي
Sorry.
هو تايم خلاص التايم خلاص خلص يعني مش
Okay.
مشكلة.
No problem. For refreshment, you can ask Dr. Shayla.
Okay. Which diseases can cause diabetes insipidus and diabetes mellitus؟
One of them is the hemochromatosis.
Yes.
Other, it could be the diabetes insipidus and any affection of the pituitary. Diabetes mellitus and diabetes insipidus. I'm not sure about the other.
Okay. A patient has polyuria. Cause of polyuria in patient with thalassemia.
What the causes?
Yes.
It could
How
be
can?
secondary chromatosis.
Secondary hemochromatosis. Yes.
Yes. It could be like the thalassemia itself. It can affect the kidney, and it could a kind of nephropathy early stage. And it could be thalassemia.
طيب how can hemochromatosis cause polyuria؟
By both affection of the pancreas and by affection of the brain in the pituitary gland.
Okay, thank you. Very good. جزاكم الله خيرا يا دكتورة. حضرتك اسم الدكتورة ايه؟
رودة.
رودة؟
رودة.
هدى؟
رودة RUDA.
رودة. جزاك الله خير يا دكتورة رودة، جميل ما شاء الله. يعني عملتيها كويس جدا، بس هو شوية تكات كده بسيطة لما اجي عليها كلنا مع بعض. الحالة كان الدكتور صلاح الله يمسيه بالخير قالها في الكورس، وقام دخل واحد من اللي بياخد معانا الكورس قال ان الحالة دي جات له في الامتحان، وجات له على انها مش ساركويدوز، جات له على انها بوست انفكشن. يعني بس هو السؤال اللي كان ناقصه انت كان عندك سيريس انفكشن في البرين ولا قبل كده؟ ده انا قلته لك هيستوري، لكن هي ما قالتلوش، فهي يعني ضيعت منه الحاله، ضاعت منه تقريبا بسبب الايه؟ بسبب كل السبب ان هو كرينيال دايبيتس انسيبيدس. لازم تسال على ايه؟ سيريس انفكشن في البرين.
يس.
يعني كرينيال دايبيتس انسيبيدس، اني تروما، اني سيرجري، اني راديشن، اني سيريس انفكشن في البرين. الحاجه برضو اللي قالها، قال ان انا ما نقصوني علشان ما عملتش تشيك للديهايدريشن.
يا في الاكزامينيشن. يس.
في الاكزامينيشن اول حاجه نعملها في واحد زي كده انك تشيك الديهايدريشن، سواء بقى بالسكين او بالماوس، بالتورش بالماوس عشان تشوف الديهايدريشن.
يس.
هديني
I
نقطتين
agree.
لأنهم هدي ياكلوا في دبي. خلاص.
What you said,
طيب
last thing, دكتورة شيماء.
نعم.
Last thing what you said, I couldn't hear you.
بقول لحضرتك الحالة دي جات زميلنا ده في دبي.
Okay.
خلاص. طيب احنا قلنا ان الاسئله اللي بنسالها المفروض ان انت تساليني كم مره تقريبا بتخشي الحمام. انت سالتيني بتصحي في النوم من النوم ولا لا، ده سؤال كويس. السؤال
Yeah.
التاني كم مره بتخشي الحمام تقريبا رفلي كده الاماونت قد ايه. خلاص انت
Yeah.
بتشربي ميه كويس، انت سالتيني انت بتشربي ميه كويس ولا لا. بعد كده ابقى حاطه في دماغي ديفرنشال دايجنوز اللي انت حطيتيه في دماغك، دايابيتس ميليتس ودايوريتكس وايه ودايابيتس انسيبيدس
Dr.
وديبريشن.
Shima, please try to speak in English. We have nice Arabic, okay?
Differential diagnosis will be one of 6D: diabetes
Okay.
mellitus, diabetics, diabetes insipidus,
Mhm.
either cranial or nephrogenic, depression
أها.
اللي هي تبقى psychogenic polydipsia، أو
أيوة.
defect in the kidney function اللي هو الايه acute renal failure may cause this, or diseases cancer as multiple myeloma, any disease cause high calcium.
أيوة. Yes.
Sarcoidosis, multiple myeloma, أي cancer. الدايابيتس mellitus انت اكتشفت انك you asked me about appetite and about weight. You can also ask, you check your blood sugar recently.
Yes,
You
I
have
agree.
diabetes. You have a diabetes.
I agree.
انت يعني you asked about the diuretic كويس. بس الكرينيال النيفروجينيك diabetes mellitus نيفروجينيك الكرينيال you should ask about any serious infection in the brain. انا قلتها لك كباست history.
Yes.
Okay.
Yes.
You asked about lithium and the medications.
Yeah.
Okay. Symptoms of hyperglycemia you asked about all.
Yeah.
Examination, we should examine first. Number one, examine the rash as you did, and examine check for dehydration, mouse وبلس وكده.
Yes.
By torch for as you say as you did by torch for the eye redness.
Yes.
We should examine الفيس for parotid enlargement.
It also happen in sarcoidosis,
Yes.
دكتورة شيماء.
Yes.
Okay.
And the
Okay.
neck for lymph nodes. Okay.
Yes.
As you said, we should examine the chest for and auscultate for upper fibrosis.
Mhm.
After that,
Yeah.
differential diagnosis, as you said, number one, sarcoidosis, number two, cranial diabetes insipidus. Sarcoidosis itself may cause cranial diabetes insipidus and nephrogenic diabetes insipidus. Can cause both.
Yes.
Okay. Investigation, and I will divide the investigation into 3 parts: basic investigation, as you said, and to confirm the diagnosis. I will do. There is no anticholinesterase inhibitor. No, this is present, not present here يا دكتورة رضا. احنا هنا بنعمل chest X-ray looking for bilateral hilar lymphadenopathy. بنعمل increase الكالسيوم level والACE
Dr.
level.
Shima, yeah, just mentioned it's for myasthenia gravis, Dr. Roda. Don't mix.
Yes.
Okay.
Anticholinesterase for myasthenia gravis, okay? Go ahead,
Sure.
Dr. Shima, sorry.
Yes.
Okay.
ACE level and ESR with reactive protein. We have 4 investigations. 4 investigations for sarcoidosis: chest X-ray, and increase in calcium level, increase in ACE level, ESR with reactive protein. We also take biopsy from lymph nodes if we can, and we will find non-caseating granuloma.
Non-caseating granuloma, yes.
Okay.
Okay.
To confirm diabetes insipidus, we will do 3 things: plasma osmolality and urine osmolality. As you said, plasma osmolality will be very high, and urine osmolality will be very low. And you will do water deprivation test.
Yes, water deprivation.
Water deprivation test, followed by desmopressin.
Yes.
To know if it is nephrogenic or cranial. Okay.
Okay.
After that, treatment of sarcoidosis is multidisciplinary team, and we
Okay.
will use steroid, indication of the steroid, as you said, when the calcium, high calcium, neuro involvement, cardiac involvement, parenchymal lung disease. involvement of the lung. Okay, or uveitis.
Okay. Oh, okay.
You said the stages of sarcoidosis very good. Stage 0 normal. Stage 1 bilateral hilar lymphadenopathy. Stage 2 bilateral hilar lymphadenopathy plus interstitial infiltrate. Stage
Okay.
3 there is no bilateral hilar lymphadenopathy. There is diffuse interstitial infiltrate.
Oh, okay.
Stage 4 diffuse fibrosis. Okay.
Stage 4 diffuse fibrosis. Okay.
Okay. How we can treat cranial diabetes insipidus by desmopressin. How we can treat the nephrogenic diabetes insipidus by thiazide diuretics. Okay.
Okay. Okay.
Okay. Diseases cause diabetes insipidus and diabetes mellitus. Sarcoidosis can cause that.
Yeah.
Okay.
Yeah. Yeah.
Hemochromatosis can cause that. There is another syndrome called diadomate.
Uh-huh. Can you
Diabetes
repeat them?
insipidus. Sarcoidosis can cause.
Can cause both
Hemochrom-
the diabetes mellitus and insipidus
Oh.
and
Hemochromatosis
sarcoidosis.
can cause. Yes.
Okay.
By
Okay.
granuloma. By granuloma itself.
Yes.
Granuloma
Yes.
in the brain, cranial granuloma in the pancreas.
Oh,
Okay.
okay.
Hemochromatosis can cause
Mhm.
both. There
Okay.
is
Yeah.
syndrome called diadomate syndrome,
Yeah.
which
Yeah.
is consists of diabetes insipidus, diabetes mellitus, optic atrophy, and deafness.
Oh, okay. Okay.
اللي هي Wolfram syndrome.
Oh, sure.
Wolfram.
Okay. Good.
Okay. Causes of
Okay.
polyuria in the patient with thalassemia. You said okay, because of hemochromatosis, which you can cause both diabetes insipidus and diabetes mellitus.
Yes. Yes. Yes.
Okay.
Yeah.
Okay كده ممتاز. جزاكم الله خيرا.
Dr. Shaima,
نعم.
may you write the investigation for the sarcoidosis and the causes of the diabetes insipidus, the 6Ds on the chat box, please? The investigation for sarcoidosis and the causes for the Ds in the chat box.
I will write it in the group because I don't ما بعرفش اكتب في الشات بوكس. هكتب في الجروب. Okay.
Okay. Okay, just
Sure.
write it in the group and I will share it here. Thanks,
شكرا.
Dr. Shaima. Yeah, good refreshment for this topic. And well done, Dr. Roda. Actually, perfect. You did it great. You
Thank
didn't miss major things. You just miss small and not high deduction of the mark in the history and the examination.
Thank
So let's start from the beginning. Onset, course, duration. You ask all this and previous attack. I mean before. Then you ask a lot of questions to analyze the polyuria well. Actually, my advice for the polyuria topic to write the reason of polyuria and to analyze it. Sorry, to write the differential of polyuria and try to catch the cause by asking the questions. For example, 6Ds, which mentioned by Dr. Shaima, diabetes mellitus, diabetes insipidus, either cranial or nephrogenic, then drugs can cause also drugs. You can add also infection. Don't miss the parathyroid adenoma and cancers and sarcoidosis. Those and psychogenic polydipsia, of course. These differential, you can ask them one by one in the history to roll out or to roll in what in the case. For example, in this patient, when you ask for the polydipsia and polyuria, so you can include diabetes mellitus and sarcoidosis and any cause of hypercalcemia, parathyroid adenoma, for example. But you can roll out parathyroid adenoma by asking the swelling in the neck, and you should do it in the screening of hypercalcemia. This is the case of polyuria. I suggest to do it in this way because if you go system review without catching the possible differential, you will not reach to your case. But Dr. Roda did it also by another way in the system review, and she tried and she reached to the diagnosis. And when she analyzed for the pain and the gravels, and the gravel it was on and off, tummy pain, and the mood, and the constipation, all these symptoms going with hypercalcemia. So it's related to hypercalcemia. Then the other system, you ask Dr. Roda the constitutional symptoms for the weight, for appetite, and temperature, lumps and bumps, and shaking, and feeling thirsty. Feeling thirsty, this is for diabetes. Okay. So what the benefit of constitutional symptom in this patient, Dr. Roda? What do you think? If you have loss of weight along
Yes,
with the sweat, so what you might think about
it
lumps or
be like
lymphadenopathy?
could be part of the sarcoidosis itself, like a vasculitis, for
Oh,
example, or
mhm.
could be like a cancer
Excellent. Yeah.
if there is myths and hypercalcemia.
Yeah, yes, cancer. So you have a lot of cancer with the hypercalcemia. One of them
Yes,
multiple myeloma, but in not in old age, but any paraneoplastic, yes, paraneoplastic. You can think about
yeah,
especially squamous cell carcinoma. It can present with hypercalcemia. So everything can be in this patient. So put the differential and ask target question for the causes. For diabetes, for diabetes insipidus, diabetes mellitus, and for the sarcoidosis. Then ask for hyperparathyroidism, yes, for parathyroid adenoma, for example, cancer and multiple myeloma in the cancer, and psychogenic polydipsia, and the diuretics. These are the common causes, and if you ask all the system related or question related to the differential, you can catch your diagnosis. Okay, let's go back to the system review you did. CNS, the mood will be affected, of course, due to hypercalcemia. Headache, it's irrelevant in this patient, and it was not significant, not signifying anything. It was 3 out of 10.
Calcium, doctor,
Really,
calcium. Due to high
okay.
calcium.
But it's not, I mean, it's not alarming headache. Yeah,
Calcium.
you're right. Yes, there is a headache, but it's not like the mood. Yeah, there is mood change, depression with the calcium. But I agree, there is headache, but it's not alarming headache. Okay. Uh, the CNS, sorry, the cardiovascular, racing of the heart, chest pain, it's only signify what can signify here, Dr. Roda, if you have heart racing or awareness of heartbeat.
if she has awareness of her heartbeat, it could be like the dehydration itself,
Okay,
and
tachycardia could be okay, but if
yeah, and it
brady, do you
could be
think
electrolyte
brady?
imbalance, and the
Okay,
sarcoidosis itself it cause the heart.
it cause what? Brad,
Sarcoidosis itself it can affect the
excellent.
heart. Yes,
Yeah, infiltration, yes. So
yeah.
cardiomyopathic. Yeah, cardiomyopathy, restrictive cardiomyopathy. Yes. Short QT. Yeah, short QT syndrome and hypercalcemia. Yeah, the opposite of long QT. Yes. Okay, this is for the heart and chest pain.
ECG changes
Gastro,
for calcium, short QT.
yeah, short QT. The opposite of hypocalcemia and long QT. Short QT. Okay, GI, very common in the GI, the hard motion for the hypercalcemia. You can find also tummy pain in the back or in the flank, and you might find the pain going or goes to the groin, and sometime with the stones, the pain will be radiated to the external genitalia, either male or female. So this is very important in this patient, GI system. The skin, very important. The skin rash, it's already known as erythema nodosum. It's very common association with sarcoidosis. And you should analyze, or you can leave it for the examination. If you know it, don't waste time by asking, is it itchy, is it painful? You can do this in the examination because you have a lot of finding and a lot of differential. The joint pain, sometimes there is joint pain related to the hypercalcemia. What do you think, Dr. Roda, might be in this patient with hypercalcemia, the joint?
Sorry, doctor.
The joint
It could be
affection
part of
and hyper.
sarcoidosis.
Yeah, okay. Through what?
Sorry.
The joint affection in sarcoidosis and hypercalcemia.
Mm-hmm.
Pseudo-gout?
to pseudo-gout
Pseudo-gout, yes.
or
Yes.
Lofgren syndrome.
Yeah, Lufgren syndrome. This is for lymphadenopathy and polyarthralgia, yes. But pseudo-gout, simply hypercalcemia can cause pseudo-gout, yes. Okay. And then we'll go to the social family history. If there is family history of psychogenic issue for parathyroid adenoma for men, you can think about hyperparathyroidism. Travel history in UK, it's relevant here, unless there is some infection can cause, but also it's not common infections. Medical history, very important here. Medication, then medication, then medication. Maybe the patient on diuretics, and this is the case. And the surgery, as you ask, it's great question to rule out any brain surgery for diabetes insipidus, or radiation, the same, or trauma for again the cranial diabetes insipidus. Okay, allergy to any medication and any water pill. Yeah, very important, water pill medication. HIV, any association with HIV here? I don't think. No, no HIV related cause for the sarcoidosis. Okay, let's go to the examination. As Dr. Rhoda started, she started by the rash because it's very specific and diagnostic for the case. So inspection and by the look first, the inspection, the redness, nodular, and you will ask, is it painful before touching it? Is there any pain? Because if there is pain, don't touch the patient. If the patient will ouch, it will harm the patient and it's against the welfare. So ask him before touching, and while touching, touch it by the dorsum of the hand to feel the temperature above and below and on the level. Then the HE and the oozing, just to know if there is any ulcer, and pulse above or below, just to rule out any affection of the vasculopathy. This is for the rash. Of course, we will start by the general look, as Dr. Roda missed the dehydration sign. It's very important. Sorry, before going to the rash, we should do general examination. General examination for the look and dehydration sign. The skin for the eyes, for the mucous membrane. Can I see your tongue and the skin tap? You can feel if the patient is dehydrated or not. Then you will go for the rash specifically. Then for the sarcoidosis, I will go to the chest. The inspection, palpation, percussion, auscultation. It will show you the restrictive pattern of fibrosis, I mean, and affection of the pulmonary function test in the form of restrictive pattern. I mean, in inspection and palpation, percussion, auscultation. I guess all clear, or I should mention them from the start. Inspection, it will be no scars. At the end of the video, you can notice the expansion of the chest may be limited due to fibrosis, if there is fibrosis in advanced stage, I mean. And this is by inspection. Palpation, you will do the palpation by the expansion of the chest, putting the hand on the chest and check for expansion in front. Then percussion. Percussion may be normal. Unless there is some fibrosis basal, you will find maybe you can feel dull or little dull, not that much dull.
Basal or on the upper part?
Sarcoidosis in apical.
Yes. I think it is apical.
I'm not sure, Dr. Shayma.
Yes.
دكتورة هدى.
Sarcoidosis
Sarcoidosis
upper?
in the upper lobe of the lung. Yes.
I think
Okay.
upper, yes, I think so.
Yes,
Yeah. Okay, great. So then we will do the auscultation. Auscultation in any fibrosis, crackles which didn't or doesn't disappear with cough. This is the case here. Then at the abdomen, you can check for the kidney, palatable, any enlargement in the organ in the body, in the tummy, I mean. Offer the lymph node, either groin or axillary or cervical, and offer also external genitalia, just to rule out any infection for UTI, because it might cause also polyuria. That's it. This is our case, our differential. You can put two differential in one word. Diabetes insipidus, either cranial or nephrogenic, and the sarcoidosis, of course, our case here. Then you can put diabetes, you can put diuretics, you can put parathyroid, hyperparathyroidism, but you can mention what against and what with in each case. Let's go to the investigation. I guess Dr. Shema explained everything apart from ACE, elevated ACE level. You didn't mention Dr. Shema and Dr. Roda also. It was missed.
ACE.
You said it? Okay, sorry.
Yes.
Okay, okay, I'm sorry. And then ECG, echo for restrictive cardiomyopathy, pulmonary function test, restrictive pattern, chest X-ray, high resolution CT chest, very important in this patient to stage the disease. Hypercalcemia, hypercalciuria, very important as well. The stages again for sarcoidosis, stage 0 normal, stage 1 bilateral hilar lymphadenopathy. Stage 2 you will add infiltrate to the lymphadenopathy. Stage 4 you will remove the lymphadenopathy and the infiltrate only. Stage 5 fibrosis, F for F, fibrosis for 5. Okay, for the management. Sorry?
There is 4 stages only. There is stage 0 and stage 1, 2, 3, 4.
Yeah, so sorry, 4, yes. Stage 1, 2, 3, yeah. 0, 1, 2, 3, 4. 4 for fibrosis, F for F, sorry. I said 5, sorry. Okay. The medication, sorry, the management, always remember multidisciplinary team approach. What team you can involve in this patient? You can call endocrinologist, pulmonologist, nephrologist, psychologist, even the patient is psychogenic polydipsia, you can nephrologist for the ruling out DI and the cranial cause of DI, and specialized nurse, GP, occupational and social worker. Then the non-pharmacological counseling education about the disease and the complication, association, the compensation, very important, and dehydration. The eye, I missed the eye examination. Yes, it was very important for the eye examination and the driving. Dr. Roda asked this question also very well. Then the pharmacological, I will think about steroid in case of neuro affection or skin affection or advanced stage of lung affection. Prednisolone for long term and tapering over 6 months. This is the case. You can add also steroid sparing agent in some cases in advanced stage if not responding to steroid. Any question or any comment? I hope the topic, it's nice topic, Dr. Thank you, Dr. Shema. It's a high yield topic in the exam, and usually it comes with erythema nodosum, and sometimes it comes like hemochromatosis, as you mentioned, hemochromatosis with diabetes insipidus, hemochromatosis with diabetes. There is always association between both of them. And you can add, as you said, serum osmolarity, urine osmolarity, and deprivation test to rule out psychogenic polydipsia and DI, cranial, and nephrogenic. Yes, Dr. Shema. Any
I want to
question?
add something. I wanted to add something now.
Yeah.
I read about Love-Green syndrome,
Okay.
which my
Yeah.
colleague
Yeah.
said about
Yes.
it. Love-Green syndrome, I read now about it. Love-Green syndrome is a specific acute clinical presentation of systemic sarcoidosis. consisting of classic triad of fever, erythema nodosum, and bilateral hilar lymphadenopathy. It is associated, however, this characteristic triad is not always present and has also been associated with migratory polyarthritis. يعني ممكن
Yes.
البرزنتيشن تبقى عندي مش من 6 شهور، مش كرونيك، مش ممكن تبقى اكيوت مرة واحدة فيفر
Yes.
وعندها فيفر وعندها erythema nodosum وعندها دراي كاف أو عندها bilateral hilar lymphadenopathy. فيعني
Yes.
أنا
Right.
قلت أوهام.
Yeah. Thank you, Dr. Shaya. And don't forget the complication of sarcoidosis. Sarcoidosis infiltration in any area in the body, the brain, in the lungs, granulomas. And yes, by the way, we didn't mention non-caseating granuloma disease. You should mention it. Okay. So neurosarcoidosis, the cardio-restrictive in the heart, I mean, infiltrate of the heart, cardiomyopathy or restrictive cardiomyopathy, and the block or the AV bundle, and it can cause AV block, and the association erythema nodosum. This, I think, the complication associated with sarcoidosis. Any question or any comment you can add, please?
Yes, thank you, Dr. Basim. So it was a great review regarding hypercalcemia. But I would like to add one point. In hypercalcemia or in polyuria cases, I think men's syndrome should be raised clearly.
Yes.
Because the men's syndrome, I think the MRCP bases, they like it, even in the MCQs and even in the orientation of the MRCP. And we should ask about the previous thyroid surgery in the family or for the patients regarding a medullary thyroid carcinoma. And we should ask about the neurological symptom regarding pituitary adenoma, especially visual field defect, visual loss. The second one regarding men, and the third one regarding the insulinoma or peptic ulcer disease, or even I think men too, also.
Pheochromocytoma. Yes.
Yes, which is include pheochromocytoma.
Yes.
Thank you.
Yeah, you're right. And it will be adenoma, not cancerous.
Yes.
Parathyroid
Yes.
adenoma and all type, yes, of men.
Yes.
Yeah, you're right.
Parathyroid hyperplasia, actually. But we should raise the concern about men syndrome in the
Yes, sure.
in the polyuria cases. Thank you.
Yeah, you're right. Okay, thank you, Dr. Hassanin. Any other comment? Yeah, I forgot to mention the management of hypercalcemia in patient or in this patient or in any patient.
Yes,
If
acute.
resistant hypercalcemia, it's very important.
Fluid.
Hypercalcemia, yes, hypercalcemia can cause short QT and arrhythmia, and sometimes it might be with the symptomatic hypercalcemia, either the stones or the depression or the what else? The blocks. Yes, so there is a specific management for the hypercalcemia. First, you'll start, as Dr. Hassan mentioned, by fluid, good hydration. Even you can follow that by furosemide diuretics and calcitonin, I guess.
Yes,
One of the lines of the management.
Yes,
Bisphosphonate takes more time.
Yes.
Yes.
Palindronate IV and calcitonin in acute stage and IV normal saline, more than 5 liters per day. Yes, this is actually the acute management. I think
For
we should.
hypercalcemia, yes.
Yes, we should say it in the firstly in the management plan.
Yeah.
I don't know if it is a priority or not, but if the diagnosis was clearly is hypercalcemia and polyuria, we should say acute management and a chronic management regarding of sarcoidosis. Acute management include IV normal saline, plus minus diuretic. There is some debate regarding Lasix. Some resources remove the Lasix from the management, and some still have the Lasix in the management. then palindronate, I think IV, overall bisphosphonate IV, and calcitonin.
Yeah. And in the resistant case, you can consider dialysis
Yes,
by
yes,
nephrology.
of course.
Okay. Yes. So this is the topic here. Let's read the comments. Then
Excuse me,
please,
Dr.
Dr.
Basim.
Yeah, sure, sure. If you comment, you are
Yes,
welcome.
if examiner asked us what is the mechanism by which hypercalcemia occurs in sarcoidosis?
Again, the mechanism of hypercalcemia and sarcoidosis.
Yes,
Yeah, hypervitaminosis D.
yes, yes. Because
Actually,
there
it
is
is,
activation of vitamin D لأنه في الجرانيولوما there is 1 alpha
yes,
hydroxylase enzyme.
yes.
Yeah,
Activation
this
of,
activation of vitamin D
yes, activation
so
of
increase the absorption of
vitamin D
calcium.
inside the granuloma of the sarcoid.
Yes, so increase calcium absorption. That's
So
Yeah,
I will,
thank you,
in
Dr. Sams.
investigation, I will do vitamin D also.
Yes, of course. Vitamin D. So, Dr. Shema, any electrolyte imbalance, do full electrolyte screening. Especially those with calcium or phosphate. For example, the osteoporosis and osteomalacia disease, bone disease, do parathyroid hormone screening along with calcium, phosphate, magnesium, and full electrolytes. Okay, any bone disease, of course, along with alkaline phosphatase. This is specific for the bone. Alkaline
It is,
phosphatase,
yes,
vitamin D, and phosphate and magnesium and calcium. It's called
it is,
parathormone profile.
yes, or sometimes called a bone profile. Yes,
Yeah, bone profile or
yes,
yes,
yes.
parathyroid. Yes,
PTH, serum calcium, serum phosphate, alkaline phosphatase, ALB, and
yes,
sometimes 24-hour urinary calcium.
yeah. Yes, Dr. Shema. Any question else? Dr. Roda, please write your case until I finish this comments in the chat box. Dr. Abdullah said
Okay.
should ask from familial cause of hypercalcemia, like familial hypocalcemia, hypercalciuria. We need to do 24-hour uric calcium. Yeah, I guess this patient will be presented younger than this, and he will be presented with multiple renal stone, and he will be hypocalcemic and hypercalciuria, calcium in urine. Yes, you're right. Short QT and hypercalcemia. Yes, you're right. Hypocalcemia cause long QT. Yes, and the opposite for hypercalcemia. Pseudo gout. Okay, thank you. Nice discussion, nice case, Dr. Shaima, and well performance, Dr. Roda, as usual. I hope to
Thank you.
take the advice for any polyuria case by checking the differential or writing the differential in the side paper and try to catch or to roll out and roll in the case one by one because it's important. If you miss one of these differential, you might miss the case because it's not related to system review. Hypercalcemia, yes, you can find, but what if you miss the psychogenic polydipsia by asking any depression, any social problem, and the patient is just drinking a lot of water, and you will ask her or ask him how many uh, bottle of water you are drinking per day. It's very important. Maybe she's just drinking fear of dehydration, and this the drinking or much drinking will cause the psychogenic polydipsia, and everything will be normal in this patient. Nothing apart from some social or psychological disturbance, which can distract you and you can think about hypercalcemia, but you will not find the other hypercalcemia signs and symptoms. So better to make it in causes and ask each cause separately. Okay. Miss Sally, 30 years, complain of recurrent hypoglycemia for 1 month. Okay, Dr. Shaima, take 2 minutes. Okay. The good thing is no Sally in the group, so we can accept this name. Okay, ready, Dr. Shema?
One more minute, please.
Okay, one more minute.
Okay, start.
No, she asked for 1 minute more.
Sure.
Okay.
يلا بإذن الله نشتغل.
Ready?
Okay.
Okay, let's.
Good morning. I'm Dr. Shayma, the doctor in the medical unit today. Are you Mrs. Sally? Miss Sally, 30 years old.
Yes, doctor.
Miss Sally, today we are here to discuss issue related to your health, and I will examine you. Okay.
Sure.
Okay, Miss Sally. It came to my knowledge that you are complaining of repeated attacks of low blood sugar. Can you please tell me more about that?
Yes, doctor. This actually recently, for the last 1 month, I haven't got this problem before. And actually 2 times I have been in the emergency department for this. And when they gave me a sugar, immediately I improved.
I'm sorry for that. Miss
Thank
Sally,
you.
do you have diabetes?
No, not really. No,
You don't have diabetes. Before this
no.
1 month, check your blood sugar and there is no diabetes.
Yeah, before this 1 month, and I haven't had diabetes in my life.
What?
I
You
have
don't,
no
you don't
diabetes.
have, okay. Okay, Mrs. Sally, you have this is only since 1 month, you have 2 times, only 2 times. Yes.
Can we take a break, like a 1 minute? 1 minute.
Okay, I will
Just
make
pause,
pause till you
Victor.
come back. Okay, yeah, okay.
ممكن اغش بقى دقيقة.
Okay, just give me 1 minute. Collect your thought, Dr. Shayma. Now you rolled out diabetes, so collect your thought again.
কথা বলে শুনে সবাই সীমায় ক্লিক করে।
Yes, sorry, may you continue, Dr. Shaima? I'm sorry.
Okay, Mrs.
Okay.
Mrs. Sally.
Yeah.
Okay, Mrs. Sally, you didn't have diabetes as you said to me. Okay, do
Yeah.
you have any family history of diabetes?
No, not really.
Okay, Mrs. Sally, can I ask you, this is 2 attacks only during these last 2 months, 1 month, yes?
Yeah, actually, it's more than 2 attacks, but 2 of them I have been taken to the emergency, doctor.
Okay, how frequent this attacks come?
It happened more than 5 times this month.
Okay, every time you measure your blood sugar and it is low, yes?
Exactly, doctor.
Okay, Mrs. Sally. Okay. Mrs. Sally, can you please tell me, do you have any post-medical history or surgical operation to be aware of?
Not really, doctor.
Nothing. Do you take any medication, Mrs. Sally?
Any medication like what?
Any medication? Show me your medication list.
Just I'm taking a paracetamol for a headache, simple headache.
Okay. What else?
Sorry?
Any herbal medication?
No, doctor.
Okay. I'm sorry to ask you that any recreational medication, drugs?
No, doctor.
Okay. Only paracetamol. How frequent you take paracetamol?
I'm taking the paracetamol like every like 4 days. I don't have headache
Okay.
all the
Miss-
time.
Okay. Mrs. Sally, you have headache also.
Yeah,
Yes. Can you please describe to me this headache?
it's like a dull aching, doctor.
In which side of your head?
It's in my forehead and above my eyes, doctor.
Okay, it is increasing by coughing, sneezing, leaning forward?
No, not really.
Not really. Is there any problem in your vision?
In my vision, no, doctor. I'm all right.
Okay. Is this headache more in the morning or more in the evening or also through the day?
Actually, yes, it's more in the morning, doctor.
Morning.
Yeah.
Okay. Mrs. Sally, do you have any change in your weight?
Yeah, doctor, I gained weight, doctor, and actually it is not intended. I gained about 3 stone in the last
Over
2 months.
2 months. Okay.
Yeah. Yeah.
This weight gain, Mrs. Sally, is not attended as you told me. Please, can you describe this weight gain? It is all over your body or it is
Yeah,
mainly
all over.
all over your body?
Correct.
Okay. Okay. What about your appetite?
My appetite, the same, doctor. I have no change.
Same appetite. No change of appetite. Okay.
Yeah.
Okay. Okay. Can you please tell me more about your activity?
No change in my activity, doctor. No
your
change in my
exercise?
diet.
Okay. Okay. Mrs. Sally, just 1 minute. Do you have any weather preference, Miss Sally?
Any what? Weather preference? No, doctor.
Yes. No weather preference, no cold preference, no hot preference.
No, doctor.
Any dry skin?
No, doctor.
Okay. Mrs. Sally, do you have any attacks of hunger with
Of
dizziness?
hunger?
Yes.
Actually, doctor, in Ramadan,
Yes.
I had this, the previous month is Ramadan, and I had this like the frequent attack of low sugar when I felt dizzy and I was about like to lose consciousness. And I
Yes, yes.
had this attack more when I'm fasting, doctor.
Yes, and you break your fast, yes?
Yeah, I should break it.
Yes, yes. Okay. Okay, Mrs. Tani, okay.
Sure.
Can I ask you some question, Mrs. Tani? Do you have what about your do you have any high fever, high body temperature?
No, doctor, not really.
You don't have high body temperature. Any feeling tired?
No,
Any feeling sick?
no.
Any night sweating?
Sweating just before fainting, doctor. I feel sweaty.
Okay. Do you have any dizziness when standing from sitting position?
No, doctor.
Okay. Mrs. Sally, do you have any heart racing?
Just before the attack, doctor. Before the dizziness.
Okay. Okay. Do you have any shortness of breath?
No,
Okay. Do you have any lower limb swelling?
no.
Okay. Do you have any hard motion?
No, doctor. Thank you for asking, but no.
No loose motion?
No change in my emotion.
Okay. Any tummy pain?
No, doctor.
What about your water work?
My water work is the same, doctor.
See, no change in frequency.
No, doctor. No, not.
Okay. Okay, Mrs. What about, do you have any joint pain?
Actually, no.
Any skin rash?
No.
Okay, Mrs. Sally. Mrs. Sally, what about your period?
My period is all right, doctor.
It is regular?
Regular with normal amount and the
Okay,
same,
okay.
doctor.
Can I ask you some private question? Are you married?
Yes, doctor.
Any chance to be pregnant?
No.
Okay, when was the last pregnancy? You have kids?
Last period before 3 days, and I have 2 kids. Yes.
When was the last one?
How old is he? He is 10 months old.
10 months.
Yeah.
10 months only. And this is problem abuse 1 month. Yes?
Yeah, only 1 month, doctor.
Okay. Mrs. Sally, what do you do for living, Mrs. Sally?
I'm a housewife recently.
Okay, is this problem affect your job and affect your daily activity?
Yes, doctor, because when I lose consciousness and thanks God, sometimes my husband with me. Yeah, it's a problem, doctor.
I'm sorry for that. I will try to help you, and I will try to help you, and I will give you global management plan. Please, Miss Sally, with whom you living?
My husband.
Okay, is he supportive?
Yeah, thank you.
You need any type of support?
No, I'm all right. Thank you so much, doctor.
Okay, Mrs. Sally, do you drive?
Yes, I drive.
I need from you, Mrs. Sally, to stop driving until further assessment. Because if these attacks come to you when you're driving, it will be hazardous for you and the others.
Sure,
Okay,
doctor.
Mrs. Sally. Okay.
Yeah.
Mrs. Sally, are you smoke?
No,
You drink alcohol?
just occasionally, like 2 units at the end at the weekend.
Okay. Mrs. Sally, can I examine you?
Please, doctor.
Okay. General examination.
She's overweight. Observational chart,
Overweight
no.
only. There is no. Okay. There is no acromegalic fishes, no cushion fishes, no specific. Huh? Okay.
No,
What about the skin in the hand? Skin, is there is any dryness on the skin?
no,
I will check the vital
normal vibe.
pulse. pulse blood pressure. I would like to check the blood sugar now and the blood pressure, sitting and
Now the
standing.
blood sugar is normal and blood pressure normal, sitting and standing.
Okay, okay. I will look for the torch by the eye by the torch. Any
Um,
redness?
and normal, no pallor, no jaundice, no redness, nothing.
Okay. In mouse, any cyanosis, any ulcer?
No.
Okay. I will chest.
Chest
If there's
examination
any
normal.
abdomen examination.
Normal.
If there is any crevitas in the knee,
No.
lower limb edema.
Not found. Not.
There is no lower limb edema. Okay.
No.
What's your concern, Mrs. Sally?
Yes. What do I have, doctor?
Actually, Mrs. Sally, before you said to me, and after I examined you, the condition you seem like to have a condition called insulinoma. Don't bother yourself by the name. Don't bother yourself by the name. We will do. This is means there is abnormal growth in your gland producing insulin, which lead to decrease the blood sugar level in your body. To diagnose and confirm this diagnosis, we will admit you and we'll do supervision, prolonged fasting test. This is you will be fasted for a long time and you will take blood samples during the attack when if it comes. And we will sit with you after that to explain to you the management plan and the result of these samples, result of these investigations. Do you have
Sure,
any other
doctor.
concern? Sure.
Not really,
Do you have
doctor.
any?
No.
Do you have any other concern?
No, doctor. Still you have like
Still 2 minutes, Dr. Shema. You can examine something else.
هو يا دكتور في الحقيقه الابدومينال اكزامينيشن مش هيتقال نورمال كده، يعني اكيد هيعدي، يعني هياخد وقت.
No, not exactly in the abdomen. There is another association with insulinoma. You can rule it out by either by the history or examination.
I will look for it. I will look for the neck. If there is any swelling in the neck, I want a cup of water to check the swelling of the neck.
There is a scar in the neck.
There is a scar in the neck. What is the scar for?
Yeah, doctor. This scar actually they took a sample from lymph node.
Lymph node?
Lymph node, yes.
If there is any lumps or bumps in your body?
No. Just this lymph node, and it showed like something benign, doctor.
Something benign. It is in the thyroid, in the gland called thyroid, or in the lymph node?
Actually, it's like in my anterior cervical area. There is a gland, lymph node, and they took a sample, and it was normal, doctor. This is why I have this scar. Yes.
You said you didn't have any family history of similar condition.
Thank you for asking me, but no.
Any family history of cancer?
No.
Okay.
Do you want to ask anything in the history again?
In the history? In the history,
The delivery?
She delivered 10 months ago.
Yeah, ask more about it. Was it eventful or no?
Can you please tell me what about your last delivery? Is there any bleeding? Is there any problem in your delivery?
No, doctor. It was like something normal, spontaneous, and
normal.
I've been discharged the same day, yes.
Okay, thank you.
Okay, time is up. Yeah, let's have the examiner and the question time.
So Dr. Shaima, what's your differential diagnosis in this case?
My first differential diagnosis in this case is insulinoma, which should be excluded first. Then I second the differential diagnosis. It may be min type 2, but against that there is no other association, other autoimmune disease or other associations. Third differential diagnosis, it may be Ben Sheehan syndrome. لا 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 I'm sorry.
Is it min 2, Dr. Shema? Wait, min 2 or min 1?
لا min 1 I'm sorry. Min 1. It may be min 1, but against that there is no association of other autoimmune disease.
What else?
It may be iatrogenic by the medication, induction by medications, but she
Good.
said to me she didn't take any medication.
Okay.
Polyuria or this like that.
Okay. So how you are going to investigate?
I will admit this patient and I will do basic investigation and I will do for her prolonged fasting, supervised prolonged fasting test. And I will, in the attack, I will measure the insulin and the pro-insulin and C-peptide. If there is
Okay, do you need to do
insulin
other investigation?
other investigation, I will check the level of sulfonylurea in her urine تقريبا. مش فاكرة urine ولا insulin.
Yes,
Okay.
yes, in urine.
In urine.
Okay. Then so how you will going to treat?
How what? سؤال.
Treatment.
If a patient is insulinoma, it will be multidisciplinary, pharmacological and non-pharmacological, and non-pharmacological education and counseling the patient. And pharmacological, it will be surgical. Insulinoma, it will be surgical treatment.
Okay. Do you want to add anything to the management plan? Any kind of medication that could be reused in insulinoma?
Insulinoma any kind of management plan, I will manage the insulinoma.
Yeah.
Insulinoma. I will give her instructions about hypoglycemic attacks, and if severe hypoglycemic attack, she may take in the acute attack glucagon, and we will teach her how she can use this in emergency. That's all.
Okay. Okay. Then what is the Weibel triad?
غيرك كنت لسه بدور عليها بقى امبارح ما جبتهاش.
You asked it during history. You asked about it. You asked about it.
I don't know Weibel triad لان انا دورت عليها من اول امبارح ما جبتهاش. قلت ادور عليها ان شاء الله.
Like the patient symptomatics during fasting, and during the symptoms, when they read the sugar, it's low, and reversed by taking sugar. You asked about it during the history.
Yes. يبقى الويبل ترايد معناها ان هو يبقى symptoms during the fasting ولو خد سكر لو خد sugar بيرجع reverse.
Yeah, and they need to check the sugar during the symptoms and should be low. Do you need to do like any kind of imaging that could be done in insulinoma?
Yes, I will do abdominal ultrasound, and I will do abdominal front ultrasound, and I will do MRI for pancreas.
Okay. Then still, I think I have no question.
Safety netting about hypoglycemia at the end.
Okay, you should. I should advise the patient about return to the ask medical advice in severe attack, and should be observed by one, and avoid driving, avoid the hobbies which may like swimming and like which may carry dangers to hair, and avoid standing in beside oven and something like that, or still alone for in a place.
Bracelet.
Bracelet, yes. Bracelet and glucagon pen should be used here.
Yeah, and candy glucose tablet. Very important to be carried. Yes,
Glucose tablet.
I think yes. Be with here. Thank you, Dr. Roda. Nice case. Thanks, Dr. Shema, for performance. Let's hear Dr. Roda
Yes.
comment. Please.
You did great. Actually, the complaint is obvious. You don't need like to analyze it more. She has a hypoglycemia. She went to the ER. They checked her sugar. It is low, and they give her sugar. Then you need to search immediately for the cause of the hypoglycemia. In this case, it could be with this weight gain. It could be like, as you said, insulinoma, pure, or could be a part of MEN1. Or it could be like patient, for example, has a psychiatric issue or something. You have to ask about the mood. Because she can take like insulin or sulfonylurea from anyone in the family. So the job here is important, and if she had any one of the family member has a DM, then this is the common thing. And then you ask for you analyze the headache, because it's simply a headache of a sinusitis. You ask about the family history late, but you ask about the medication late, but you ask. What else? In the examination, I don't think you missed anything. You ask about. I don't think the body build is overweight. You ask about the vital chart. You can look if she is anxious or something, mood, depressed or no. What else? You can offer yes endoscopy.
Yeah,
Yes,
this one
yeah.
also.
She could ask about weight gain complication. Yes. And yes, and I don't think there is anything in the examination that is. She has a scar in the neck. It could be like a parathyroidectomy scar, but simply she told you it is a lymph node. They took a sample and showed something benign. But you need to see if there is a scars in the neck for the sake of MEN1.
I asked you, Dr. Roda, about surgical disease.
Yeah, you asked me. I think you asked me. It's my mistake. And regarding the investigation, first you will check the insulin level. As you said, and you will check the C-peptide and proinsulin level, and you will do endoscopic ultrasound to see the pancreas. Okay. And you will, and I think there is indication for the supervised fasting. I don't know about them. The supervised 72-hour fasting. And what else? You can do like a PET scan. It's also helpful. Management, as you said, mainly surgical resection, but you can use other medication if the surgery is not like very like successful. You can use diazoxide, or for example, octreotide. And there is other medication. And if still not controlled, you can use chemotherapy. And I want to ask you, is insulinoma a benign or a cancer, Dr. Shaima?
There is percentage of benign and percentage cancer.
Yes, exactly. Only 10% is cancerous. Rest are benign.
How
then
much? Again, Dr. Roda.
Sorry, what you said?
How much it is cancer? 10%?
10% only.
Still, we can say like few chromocytoma, 10 cancer, and the others,
Yeah,
or the
yeah,
rest,
yeah,
the same for few chromocytoma. Okay.
yeah. And also the CT scan is not helpful in the insulinoma. If they ask you about imaging, endoscopic ultrasound, number 1. Number 2, PET scan. No role for the CT. And that's it. You did great. Thank you. You did great, mashallah.
Yeah. Thanks for the case, Dr. Roda, and well done, Dr. Shaima. Let's comment about the performance for Dr. Shaima from the start. It was the complaint of hypoglycemia for 1 month, and you ask for the previous attack, or she mentioned to you. I think, yeah, no previous attack. It was only first time, and 2 attacks of them brought me to the hospital. And you can ask also about the seizure during the attack, the loss of control. Just rule out a seizure or epilepsy. It's very important, this patient. Shaking of the hands, sweating, hunger, pain, just to confirm this is your case. It's hypoglycemia only. Then the constitutional symptoms, you ask about the weight gain, and I think you got the case from that time when you catch the gaining weight, and it was with insulinoma. Gaining weight, and you ask for the weight. Is it all over or a specific particular part in the body? It was all over, so it's not acromegaly or something with certain areas enlargement. Appetite was okay, temperature, tiredness, sweating, dizziness. It's very important here to ask about dizziness and hypotension or dizziness while standing from sitting position. To rule out Addison as autoimmune association. Then, yeah, the good question here, Dr. Shaima asked, do you have diabetes? It's very important. She might be diabetic, and all these things related to the insulin, related to erratic control of her blood sugar, oral hypoglycemic agents. So to rule out diabetes is very important, as Dr. Shaima did. This is for the medical history. Endocrine, you ask for the weather preferences. However, it will not be, if you think about men, it will not be like cancer. It will be asymptomatic enlargement. Then for the CNS, you ask for any headache. There was headache in the morning, mainly the forehead and the eye, but no alarming signs. The vision wasn't affected, and this thing can roll out, but still you can roll out, but still there is possibility to be pituitary adenoma, because if microadenoma, it might be without vision affection, although the headache will be there. So it's very important to do the vision history and examination. I don't think you did examination for the vision, which is very important. This patient just rule out bitemporal hemianopia, and in this way you can rule out pituitary adenoma as association in min1. Still min1 possibility till now. So the cardiovascular, no racing, no anemia, no chest pain. The chest, no affection here. Gastroenterology, nothing. No hard motion, no change, no tummy pain. But if there is min association, min1, you might have parathyroid affection, and it will cause abdominal pain, as I mentioned in the previous case. So it's very important here to ask about hypercalcemia. Roll out min1. Again, genitourinary for the urine or waterwork affection, skin for dryness, and sweating. You can ask for the skin as rash, darkening, joint, no affection here. Female history was important. Yes, I agree, especially if amenorrhea. What do you think, Dr. Shaima, if there is amenorrhea in this patient along with hypoglycemia?
Amenorrhea? ممكن تكون
amenorrhea.
hypoglycemia.
Excellent. Yes. Okay, amenorrhea and failure to lactate and hypoglycemia. What do you think?
I mean, if then hypoglycemia, she had syndrome. So I
Yes, yes. Yeah, it's very important. That's why I asked you for delivery. It might be affected postpartum or during delivery if there was bleeding and received blood. It's very important to ask. Any endocrine with hypo, you should ask this. I mean, pan hypo questions. The amenorrhea, affection of the libido in male, and for female amenorrhea, and hypothyroidism symptoms and signs, Addison, what else? So the Addison, ACTH, thyroid, and yeah, gonadotrophin, and maybe darkening. No, not darkening. It will be hypopigmentation. Yeah, hypopigmentation of the skin. I mean ACTH, decrease ACTH.
alabaster skin.
Yeah. Okay. Family history is very important here. Family history, and you can specify your question for family history, Dr. Shaima. Not only family history of diabetes. Okay, no diabetes. What else? And what the significance of diabetes in this patient? Family history.
Doctor,
It's
family
good.
history, I asked it again. The last family history of similar condition, mostly any cancer.
Excellent. Okay.
At first, in the
السلام
beginning, I
عليكم.
asked family history
منو؟
only for like
أي مكان أي مكان.
Sorry, Dr. Shaima, there was some noise. Okay. Dr. Shaima, again, my question. What is specific question for family history here? Very important. You ask for diabetes. What signify the diabetes?
لا أنا قلت
Sorry?
الفاميلي هيستوري لوحده في الآخر. قلت الفاميلي هيستوري
Okay.
لوحده في الآخر. family history of cancer, family history of similar condition,
Okay.
family history. برضه في الأول أنا سألتها على أي family history of diabetes. أنا في الأول كان جاي
Yes,
أنا عايزة
yes.
exclude
Okay.
إن هي diabetic.
You exclude what?
إن هي diabetic أو إن هي any chance in to be diabetic.
Okay. Okay. What else related to family history of diabetes? I agree with you. Family history of diabetes, she might be diabetic. Okay. What signify family history of parent with diabetes in this patient? What do you think?
This medication.
Excellent. Yes. If the father or mother is diabetic and this patient is psychiatric little bit, and she might take her father or mother medication like sulfonylureas, she will come with hypoglycemia. So it's related either by direct or indirect way. It's very important here. So families of diabetic, yeah, if there is positive, you can ask her what your father medication or what he is taking or what she is taking. And yeah, you can think about either insulin abuse from her father or sulfonylureas or suicide or whatever. Okay, this is for family of diabetes. Okay, what other
But
family history? Sorry.
she live with her husband. I
Okay.
can ask any one of your housemates.
Yeah, okay, great. So if she lives with her husband, you can ask her if she lives with any of her parents if they are positive. All this question if they are positive, but if they are negative, so no, not significant. Okay, let's go for the other family history in this patient. What's important?
Men one.
Excellent, yes. So min one, you can ask any gland or any families of gland disease. It's simple, or cancer at the end, plus any families of cancer. Okay, travel history here, not signifying anything. The medical history, very important. You ask good question. I like the question for herbal. Very important in this patient, the herbal. Some people and some patient taking herbal for either for losing weight or for whatever the reason, and it might be the reason of decrease her weight. Sorry, decrease her blood sugar. And two more condition I should ask, or I could ask about herbal, or three. What do you think, Dr. Shen? In bases, herbal in bases. Let's do it as a collection. Herbal in bases. What do you think? Okay, this one of them. Hypoglycemia. What else? What about diarrhea? Do you think it's signifying anything? Yeah,
Yes.
maybe the patient
Diarrhea,
is
loss of
taking
weight.
herbal.
Yes.
Sorry.
Loss of weight.
Yeah, loss of weight or diarrhea. Both of them can. Might take this herbal to lose of weight, to lose weight, and it will lead to diarrhea. And she will just come to you with complaint of diarrhea. Okay. So it might come as loss of weight and associated diarrhea. The third condition in bases,
liver failure.
hyper, yes, jaundice, and yeah, derangement of liver enzymes. Some people, especially Chinese herbal, it might harm the liver, and the patient will come with jaundice and liver failure, acute fulminant, even hepatitis. I saw a real case like this in
Again,
ICU.
دكتور, the last one what? احنا قلنا diabetes
He-
وقلنا الدايرية
Diabetes, yeah,
واحدة ايه بقى؟
diabetes, diarrhea, liver affection or hepatitis, acute hepatitis or derangement of the liver enzymes. All these can be affected by herbal medication. Okay, I found another two causes or two conditions. Do you think hypertension, patient with persistent hypertension taking licorice, it's very important to ask for the herbal, licorice specifically. And the last
بتهيألي
one,
الليكوس بيعمل هايبركاليميا صح؟ ولا
plus
هايبوكاليميا؟
yes, no,
هايبر
hypokalemia, the same
هي
effect.
مجموعة كده بتعمل
Pseudo hyperaldosteronism.
Yes, so it will
hypokalemia.
be hypokalemia. Yes, hypokalemia. Yes,
هايبوكاليميا.
yeah.
يبقى
Okay,
يبقى
one,
ده الهايبوكاليميا بنسأل بيه عليه بالاسم هايبرتنشن.
yeah, hypertension with licorice, diarrhea with orlistat or some medication or herbal related like orlistat, and liver enzymes, deranged liver enzymes or jaundice. And our case here, hypoglycemia. I remember one more, but wait, I will try to remember it. Herbal in bases. Okay. Okay, I missed it now. But at least we collect four now. It's very important in bases. Hypoglycemia, hypertension, deranged liver enzymes, and jaundice, diarrhea. These are for the herbal in bases. You can ask this question if you didn't find any of the condition or the underlying cause. Okay. Then you ask for recreational drugs. Very important here. Yes, it's very good question to ask about recreational drugs. Before that, you ask for the surgery, and Dr. Roda gave you by mistake wrong, but it's irrelevant. It's just glands, just distract you. Recreational drugs are important here. It's some of the recreational drugs can cause the hypoglycemia. Alcohol is very important here, and I was wondering why you didn't advise her to stop alcohol, even little amount. Alcohol can cause hypoglycemia, even she's drinking
even
two, but
even even little
yes,
amount.
yes, yeah. Any harm to the systemic or to the body related to the alcohol, advise her to stop alcohol, even little amount. Okay, her life or the alcohol. It might threat her life. It might come, or she might come with hypoglycemia, severe hypoglycemia next time. And you know the drawbacks of hypoglycemia. She might be vegetative all over
And she
through all her life.
is Muslim
Sorry?
as well.
Sorry?
She is Muslim as well. She is Muslim, and she is Muslim
Okay.
as well. يعني should advise
Okay.
because she's fasted.
Yes. Okay. Yeah, but in exam you can't say that. Only between us. Okay. Thank you,
So
doctor.
يعني any
Okay.
diabetic patient I should advise him to stop alcohol. Any
No,
diabetic,
no.
any
I said hypoglycemic patient. Yeah,
hypoglycemic patient,
alcohol.
even though diabetic بيجيله hypoglycemia.
Yes. By the way, Dr. Shaima, it's very important in case of unawareness hypoglycemia to ask about alcohol.
Yes.
Yeah, if the patient alcoholic and he has attacks of unawareness hypoglycemia, it's against welfare not to ask about alcohol. It might be the reason of her or his unawareness hypoglycemia. This is one of the
Yes.
reasons. Yeah, so this is, of course, for any hypoglycemia, this is another reason. Okay,
Yes.
so better to ask. Smoking, yeah, as general advice, job is very important, especially if she's working or he is working in building or something positioning with the high risk job like in heavy vehicles or driver or taxi driver or even in sun or sorry in hot weather and the patient might be more symptomatic with hypoglycemia. I mean strenuous exercise job. You can ask him or to refer him to the occupational work. The last thing, the driving, either driving or taxi driver or heavy vehicle, whatever, you should advise him to inform or her to inform DVLA.
No,
Examination, you,
no inform DVLA. Only stop until further assessment.
as initially, yes, as initially, but if she has repeated attack and you diagnose her or she's diagnosed with hypoglycemia for any reason, yeah, you can ask her to advise, sorry, to inform DVLA. But in the first presentation, yes, you can tell her, please stop driving till we reach to the diagnosis, okay?
Yeah, يعني according to Dr. Salah, he said to us, he said we inform DVLA only when stop when we stop driving more than 3 months. And if it will go surgical operation,
Okay, you
may
don't
need.
know what the consequence of this disease. She
Yes,
might
yes.
be, yeah. So I agree with anyone. For first presentation, you can tell stop driving, please, for your safety and others. Stop driving until we assess you and to reach to the diagnosis. Any reason. But if someone is known case of like epilepsy, you will not tell him, please inform me if given area. No, you will inform because definitely he will not drive before 6 months, especially if he has attacks. But in this case, first presentation, you didn't diagnose him or her. You can ask her, please do not drive till we reach to the diagnosis. Okay, let's go to in the examination. You examine the weight, the acromegaly. Yeah, good question. And prolactinoma as well, but there is no amenorrhea. Vital chart. Yeah, always start by vital chart and blood sugar. Vital chart and blood sugar, saturation, temperature, blood pressure. And when you remember blood pressure, add to the blood pressure sitting and standing. Just offer it, especially with endocrine disease, endocrinology. Okay. And the eye examination, I was waiting for you to ask for fundoscopy and for visual field by temporal hemianopia to roll it out as association with men one. The mouth, as you ask, yeah, for the mouth, ulcer and sores, it's very important. And you can also add injection mark or if you suspect she is suicide or if she is nurse or she is abused or working in pharmacy. This is the importance of the job in this patient. Then the differential, our differential in this patient, either insinoma, isolated insinoma, or in syndrome like MEN1, or as you mentioned, drug-induced either sulfonylureas or insulin, but against that, denied any of these. And I think this is the most common differential in this patient. If someone want to add comment or to add question, is welcome or she is welcome. Okay, I can read comment till someone want to add comment. One of the family member have anti-diabetic medication. Yes, we mentioned this point. Just to rule out any ingestion, either sulfonylureas or insulin. Loss of weight, hypertension. Yes, I mean, we mentioned this for the herbal. And it's better to advise. Yeah, Dr. Dalia, welcome. Dr. Dalia, long time. It's better to
Yeah,
advise.
hello.
Welcome back. How are you?
I'm fine.
Finally, you're awake now?
Yeah, awake. Yeah.
Yeah,
Many
this,
times I
yes,
was in, but I
yeah,
can't speak. Yeah.
appreciate it. Yes, I know. Thank you for the comments. Yes, what you want to add, Dr. Dalia? Yes, you can talk.
Yeah, just for alcohol, it's better
Mm-hmm.
to even, for example, if the patient have cardiomyopathy or cirrhotic liver.
Mm-hmm.
Yeah, what I see usually, gentle advice. Even the patient
Yes,
has COPD and
yes.
end this stage, just gentle, advice not to stop. Stop is bit harsh.
Mm-hmm.
Okay, so just advice. It's not yeah, in your way. I mean, not to stop it. You need to stop it. You have to advise you to drink in moderation, and if you couldn't take it, it would be better or something like that.
Yes, yes.
Yes,
Yeah,
okay.
not like order, you mean. I
No, no,
cannot
no, no,
order
at
here.
all.
Yes, yes, okay.
Okay.
So I advise you to reduce your alcohol and much better if you are not taking it. Okay, good way. Okay, thanks, Dr. Dalia. And any other comments? Any questions?
Dr. Basim, I have a question,
Yeah,
please.
yes, sure, Dr. Hassan.
Regarding the pan-hypopituitarism, what is the direct link to hypoglycemia? I didn't attend the whole
Addison,
story. Yes, yes,
Addison,
Addison disease, adrenal
yes,
insufficiency. Yes,
yeah,
but in the scenario of hypoglycemia, the link to the pituitary gland and two pathway. The first to the main one and prolactinoma. We should ask about amenorrhea, galactorrhea, reduced sexual drive, and the second pathway is for the adrenal insufficiency. Yes.
yeah, I agree with
Yes.
you. So it's important always, as you said before, men is one of the high yield topic in the exam. Do you
Yes,
like
بالضبط.
it?
Yes,
Yeah,
بالضبط.
either
بالضبط.
min 1, min 2A,
They
and this
like it,
min
yes.
2B is not that much important. However, if you find patient with Marfan, you can think about it.
Yes.
Okay, thanks, Dr. Hassanin. Any other comment? Any question? Clear? Okay, let's go to the investigation, Dr. Shaima. Yes, we didn't mention it. So always mention the general investigation. General investigation, no harm to mention them. Why? Because even the patient, it's not related to the patient case. It might be in his file like baseline. Maybe he will be a chronic patient. Maybe he will come for follow-up. So any patient who will come to you for the first time, you can say basic workup in the form of CBC, coagulation profile, kidney function, liver function, and electrolyte, full electrolytes. Specific investigation in this patient will be C-peptide and proinsulin and insulin. And you can add, yes, as you mentioned, sulfonylurea screening if you suspect. It's okay. Then the imaging. As Dr. Rhoda mentioned, the PET scan or endoscopic ultrasound. Then the association or complication. Yes, we didn't do examination, Dr. Shima. Always remember, any overweight, any gaining weight in the faces, you should do 3 examinations, starting from up, down, the OSSA, obstructive sleep apnea, I mean the neck circumference, and the tongue size, the mouth opening, and the airway from outside. I mean, you look in the airway, and polysomnography in the investigation, you will add it. Okay, this is for the neck. Carpal tunnel in the hand. It's very important by tapping or asking before tapping, and the shaking to remove or to improve it. And the investigation will be EMG and nerve conduction study. This is for carpal tunnel. The third one, osteoarthritis. It will be presented either in the knees or whatever, but it always be, or mostly it's in the knees. And you will do examination as crickles or crepitations and X-ray of the knee. Always remember those complications with any weight gain. And be smart. If you have this case, I mean gain weight, you can take the examiner to this point, telling him complication, screening for complication. Until this, the 3 points, it will take time, and you will show the examiner that you are aware about the complication of gaining weight, although it's not your case, but it's very important. And don't forget to mention about if the patient obstructs sleep apnea, echo as pulmonary hypertension, and in the examination you might find parasternal heave and loud P2. It's very important as well. Okay. Can you repeat the differential? Yes, isolated insulinoma, Dr. Rabia. Isolated insulinoma or insulinoma in men 1. Insulinoma in men 1 or drug induced. This is the causes, yeah, and differential of hypoglycemia. If anyone wrote the differential of herbal in paces, you can add it for the benefit of all group in the WhatsApp group. If no one did, I will do inshallah after the lecture or after the session. Nursing moms a very common cause. Yes. You mean for hypoglycemia? Yes. We mentioned the nursing or the pharmacist. Sometimes they are taking.
I think the fourth thing in the herbal. I
Yes.
think the Chinese herbal nitrosamine containing products which lead to esophageal CA, sequential cell carcinoma.
Esophageal cancer.
Yes. Chinese herbal
Okay.
containing nitrosamine, which is uncommon in the I think in
Yeah,
the
yeah,
basis.
uncommon, but you can add it. Yes. Lactating mom. Yes, I mean. Dr. Dalia, you can clarify for what cause for what?
Or
Lactating.
hypoglycemia, I mean.
Yeah,
Yeah,
because they
because
are
usually,
lactating, you mean? Yes.
yeah, particularly if not eating well, you know,
Yes, yes.
and yeah, even this is the same amount that they are usually taking while are not lactating or not nursing their babies. So with this, I admitted many patients with that, by the way, even with syncopal attacks, with short or brief loss of consciousness.
Yeah,
So this is very common, by the way.
yes. Okay. We can add also alcohol induced, but it will not be unless the patient is diabetic or something related to the sugar,
Yeah,
I mean, control.
binge alcohol. chronic
binge
liver disease
alcohol.
or end-stage liver disease,
Yeah,
cause
they
of
can present with
hypoglycemia.
hypoglycemia. Yes, you're right.
Yes,
So we
yes.
can add it to the fourth, chronic liver disease as a cause of hypoglycemia. Yes. Okay. Okay. Thank you. Since no other member for the communication, we will end this session today. Any question, any comment? Or if anyone grantee for communication before ending? Okay. So let's end the session, and then we will have the participant. I thank you all for attendance. It was nice discussion and nice session today and nice cases. Thank you all.